It is my pleasure to welcome Dr. Kerri Baker, Vice President, Royal College of Physicians of Edinburgh, UK, who will speak on Fit for the Future, Acute Medicine. Ma'am, please take over for your presentation. Thank you.
Microphone's off. Microphone's on, great. So that was very on brand for acute medicine because we deal with lots of the unexpected and unpredictable every day, so that was very fitting. Hopefully I've not lost too much time on my timer. So I'm going to be introducing you to acute medicine, which is born in the UK and exported elsewhere. And what we'll cover a bit today is slides aren't progressing, but we will talk a bit about what acute medicine is, what training in acute medicine involves, why it was developed as a specialty, what the advantages and challenges are, and how we make it fit for the future. Great, and we have slide action, perfect. So first of all, the simple question, what actually is acute medicine? So it's been a distinct medical specialty in the UK since 2000, and we provide the initial assessment, investigation, diagnosis, and management of patients in their first 72 hours of their hospital stay. It's distinct from emergency medicine. We often get mistaken for the two, but we are not the same, as we deal specifically with internal medicine patients. We don't deal with obs and gynae, pediatrics, trauma, etc. And we have our own specialist units for this in the acute medical unit. We also provide an outreach service for specialty teams. We provide input to the cardiac arrest and medical emergency teams. And we have very close working with quality improvement, medical leadership and management, and other improvement pathways. And all of this has made us the engine or hub of acute care, as you can see there, where we're the interface between A&E, the medical wards, and going home, but also really a prime location for high quality education and training opportunities. So this is essentially what we do. At the top left, you'll see the rapid assessment. That's the absolute core. So when I was a child, I loved doing jigsaw puzzles, and I got bored once they were completed. That's what makes me an acute physician. So we are diagnosticians predominantly. We love to solve a puzzle, and then we will either send that puzzle home or send the puzzle on to someone else. So we do the initial investigation, rapid management of patients with acute medical needs, done in these variety of settings as you see here. So at the top is SDEC, same-day emergency care. I'll tell you more about that later on. 72-hour care reflects the fact that acute medical units are really designed to focus on the first 72 hours. And if the patient needs to stay beyond that, then generally there's onwards inpatient referral to a specialty or specialty bed base. In places like my unit, we don't need to make a referral. There's just an assumption that we know the best disposition for the patients and they move onwards there. We also master alternative pathways. So examples include hospital at home or OPAT, which is outpatient parenteral antibiotic therapy, and we'll utilize as many of those as we can. And then finally, enhanced care units, a phrase which is used to describe really anything that gives an enhanced level of care, such as medical HDU. So acute medicine has grown really rapidly since its development 25 years ago. We've now got over 550 consultants in the UK specialising in acute medicine, 225 hospitals with acute medical units, including 29 in Scotland. I've marked on the map where my acute medical unit is. It's very close to our home at the Royal College of Physicians of Edinburgh. And now acute medicine is the 8th biggest specialty in the UK by consultant numbers, so we've grown pretty impressively considering that's in 25 years. That comes after cardiology, geriatrics, gastroenterology, respiratory, diabetes, hematology, and neurology. So we are a big specialty. We've had the largest increase in consultant numbers in the last few years. 2020 data showed 197 new consultant posts in the UK, although only 67 of those were appointed to. And the development and training and governance is not only undertaken by the 3 medical royal colleges together, but also supported by the Society of Acute Medicine, or SAM, which is our specialist society, which represents all staff caring for patients in the acute hospital setting. And I just include a screenshot here because they've got lots of helpful free material on their website that you may find helpful if you're setting up your own acute medical unit. So how do we train doctors in acute medicine? So I was one of the first trainees to go through the system. Entry is at higher specialty training levels, so our doctors have already done 2 years of foundation program basic training and then another 3 years of core internal medicine training. So they're 5 years postgraduate by the time they hit our doors. And then they do a 4-year training program and also a specialty certificate exam, which is the knowledge-based assessment that they need. And at the end of that, they pop out as an acute medicine consultant like myself. And during those 4 years, they really focus on the prompt, practical management of patients with acute medical illnesses, including relevant practical procedures, also the ongoing inpatient management of complex medical patients in inpatient settings. They will learn about developing new pathways to maximize safe and effective outpatient care. There's a major focus on leadership skills, so probably no surprise that you will meet lots of acute physicians in the UK which have other leadership positions. And we develop multi-professional systems to optimize patient care and patient safety. All trainees will go through care of patients needing a higher level of care, so normally 6 months of intensive care training. And then in terms of additional skills, we now mandate that trainees do point-of-care ultrasound, so they must accredit in that. And they will also have to do one mandated specialty skill, which they get to choose. And generally, that is from 4 categories. So either it's a procedural skill, such as echo or endoscopy. It may be research. It may be an additional qualification, for example, medical education for myself, management, leadership pathways, quality improvement, all similar. And then others will do a subspecialty interest, with popular and relevant ones being things like intensive care, stroke, perioperative medicine, acute oncology, obstetric medicine, and toxicology. So that is all fine and well, but medicine has managed for a long time without acute physicians. So why was it developed? So I asked ChatGPT to help me with an illustration to show the current NHS, and it gave me this rather doomsday picture for the NHS. But it's used to show that we have 5 key drivers for the establishment of that, the need for it in the UK. So the first was of rising patient numbers. So there's been a significant increase in medical admissions, which really threatened to overwhelm traditional hospital structures. Related to that, there are bed shortages and overcrowding, and it meant that patients were being admitted to unsuitable surgical or non-medical wards, leading to poor care and staff that were just unfamiliar with the complex needs of our patients. The next is the need for senior expertise, early senior expertise. So delays in senior physician review meant that really junior staff were looking after complex and often critically ill patients, highlighting the need for immediate senior-led assessment. The next was time-sensitive care, recognising that the first 48 hours in particular are really critical for the diagnosis and treatment and outcomes of many conditions like sepsis, delirium, AKI. And then finally, some positivity. There is an opportunity here, an opportunity for improved training because of the rich, structured environment that AMU provides for doctors and other healthcare professionals. So these are the advantages. These are the evidence-based advantages from the literature. So we have reduced mortality. Patients cared for in an acute medical unit demonstrate a significant reduction in inpatient mortality. Studies suggest that patients who are admitted to a structured AMU are up to 36% less likely to die than patients who are admitted directly to a general medical ward. That's quite compelling. Safe discharge, then, that's achieved with no significant increase in readmission rates. Studies suggest that acute physicians discharge approximately 12 more patients for every 100 that we see compared to our peers in other disciplines. We also have shorter stays, so this is a proven model for reducing the overall length of stay, including increased throughput, more efficient use of hospital resources, and the majority of studies show an average reduced length of stay of between 1.5 and 2.5 days. And then finally, as all part of that, we have improved satisfaction amongst patients and staff. And interestingly, studies do show a perception of increased stress. There are stresses in an acute medical unit by its very nature, but staff are still happier with it than previous models. The majority of medical and nursing staff report it's a better setting. 75% of GPs refer this model to previous ones. And all of this reflects the collaborative MDT experience we have with expert nurses, allied health professionals, and, for example, frailty teams that join us under the guidance of an acute physician. However, the NHS was originally founded for episodic care, which was basically single organ failure. And the reality of today, as we all know, is complex multi-morbidity with frail patients. And so for nearly a decade, there's been a continuum of perfect storms in the UK, which has caused significant pressures on our systems, and every winter has become demonstrably worse and worse, described by the Society of Acute Medicine as having our foundations under siege. And that results in the problems you see here, which are overcrowding, staff shortages, lack of resources, and then boarding onto medical wards, all of which then compound each other. And this results in a discordance between what we wish to deliver as acute medics and what our actual lived reality is. So the ambition is to deliver wonderfully integrated, preventative, holistic, person-centred care. And unfortunately, the reality is sometimes corridor care, capacity challenges, and these predictable winter storms. Then that problem is compounded by lack of access to the acute medical unit. So when it becomes full, sicker patients bypass it and they get stuck in the A&E instead. Society of Acute Medicine does an annual benchmarking audit called SAMBA, and the data from that over the last few years shows a clear step change every year, where patients are receiving their first medical assessment progressively more in the emergency department rather than the acute medical unit. Post-take activity in the emergency department really deprives our patients. It deprives them of that wonderful specialist multidisciplinary care that they get in an AMU. And data shows a deterioration in time to consultant review and also a 37% reduction in consultant productivity when we conduct our post-take reviews in the footprint of an A&E rather than an actual acute medical unit. There's similar problems beyond A&E, where we enter this vicious cycle of poor hospital flow. So acute medical units become stranded, with the sickest and most dependent patients having nowhere else to go. And then for the next patient, specialist care is bypassed because there's no available beds with us, so they go straight to a medical ward. And that means that the benefits of the acute medical unit are lost for those patients, including the rapid assessment and the specialist MDT teams that provides. And then that means that the whole system suffers because they lose the concentrated skills and benefits that an acute medical unit delivers. They lose the reduced length of stay, they lose the increased discharge rate. And so the hospital becomes increasingly full. And so the cycle continues. Then on top of it, there's workforce instability. To be really effective, we need 7-day consultant cover, but we've got loads of consultant gaps. This is my promotion for coming and working in the UK, perhaps. So in one study of 48 sites in England, over 9 of them had over 50% acute physician gaps, so lots of vacancies, and they end up being filled by locums or temporary staff who come at a premium cost but provide less continuity and reliability and then ultimately value. And in the meantime, our roles are often not optimized because lots of levels of staffing are short, so consultants end up doing roles that could better be done by other healthcare professionals, often cheaper healthcare professionals. There might also be a training void, so often smaller hospitals or more rural hospitals are bottom of the pecking order for trainees who are choosing their placements. And then finally, an opt-out culture can mean that specialists in various ologies may opt out of doing the general or acute take rota, and that puts increased pressure on the remaining staff. So currently about 55% of medical physician consultants in the UK contribute to the acute take, but it's really variable depending on what discipline and what region you practice in. So with all of that in mind, how do we make acute medicine fit for the future? In the words of our specialist society, we cannot rebuild a burning platform simply by tipping it upside down. So that means we need to move to our traditional model of firefighting to fireproofing our acute care pathways. How do we strengthen those foundations? Well, in the words of Society of Acute Medicine, never has the need been greater to re-establish and strengthen our foundations from which acute medicine can play its pivotal role. The core principles are here. So first is to protect the AMUs to ensure its functions are preserved and therefore our patients are preserved. 2 is to share the responsibility. So the management of the acute take does still have to be shared with all the general internists. So it's not the sole burden of the acute medicine consultants. And then thirdly, we have to invest in people and really protect time for that high quality training that AMUs provide and recognize that it's a really rich learning environment for staff of all backgrounds. Here's my workforce prescription. So I've already said we want physician-led multidisciplinary teams 7 days per week, should be for at least 12 hours a day. We achieve that in my hospital, but it's not easy. This allows a model of early senior review, which is critically important. And that allows early redirection or early discharge. It prevents wasteful double clerking that's not needed for patients who could go home. And it involves a move to live reviews in real time rather than the much less efficient post-take activity that places historically use. We need to optimize roles, so to ensure that consultants are consulting, and that involves optimizing and utilizing other staff like ward clerks, porters, coordinators, but also better technology. So my hospital has no electronic health record, for example. We could have better access, better patient tracking. All of these would make us more efficient at our jobs. And then finally, there's no point in having a consultant present 12 hours a day, 7 days a week, if you don't have access to diagnostic services to support that. So extended hours for CT, MRI and ultrasound, and extended services to support staff individually as human beings, so WhatsApp group and peer groups are helpful. Admission needs to be the last resort wherever any alternative that is safe exists. So this means that ambulatory medicine or same-day emergency care needs to become the norm, with access for GPs and A&Es and ambulances directly. Currently, only about 64% of UK hospitals have an SDEC that is open 12 hours per day, 7 days per week, but that needs to become the standard. A case example is in Croydon in England, where there's a specialty nurse-led service that sees 70% of all same-day referrals to medicine, and it's reduced length of stay by 27%. Physician-led hospital at home and virtual wards also need to be expanded, so these can look after selected appropriate patients with things like intravenous fluids, antibiotics, oxygen, and diagnostics. Hospital at home has an average saving of £2,000 per patient, so that's around 500,000 Pakistani rupees, and it reduces delirium and institutionalization in frail older patients. In Scotland, hospital at home last year saved over 16,000 patients from being admitted to hospital. And then also a really major concern in the UK is we need to bolster our primary care access and mental health services, because those patients often have nowhere to go and end up in our units where they would be somewhere much more appropriate. I've mentioned SDEC, that's same-day emergency care, the same thing as ambulatory medicine, so it provides same or next-day emergency outpatient care with rapid assessment, diagnostic and treatment for patients who are urgent but still don't need to spend the night in our hospital. And in places like my hospital, that's further split into an SDEC, a same-day frailty unit, a nurse-led DBT clinic, and a microbiology-led outpatient parenteral antibiotic therapy unit. It's a bit of a mouthful, but it works really well. And this is an alternative to admission for things like DVT, PE, cellulitis, headache, syncope, anemia, where we can sort people out pretty quickly or the next day, but they don't really benefit from being in overnight. Patients tend to stay for about 6 hours. And we use that to avoid admission, but we also use the unit to facilitate early discharge from other units to keep hospital flow going. You like this? So this month, Glasgow launched this car. It's a diagnostics car with access to portable X-ray, ultrasound, bloods, and urinalysis. And it is supporting hospital at home services around the city of Glasgow. Our current IT infrastructure for such a developed country is woefully poor. Whenever we ask for more better IT in the NHS, we get given these dreadful computers on wheels with a horrible battery life and no Wi-Fi connectivity, and they die a death in a corridor somewhere. IT system failures have been responsible, or at least linked to the death of 3 patients in NHS England and the harm of many more in recent years. So it's a really important issue that we get reliable IT access and seamless real-time data exchange across all settings, including to and from primary care. We also need multi-specialty in-reach on a daily basis for high-volume specialties. So, for example, my hospital has an acute frailty round every morning. The gastroenterologists and renal physicians will routinely visit. A chest pain specialist nurse and asthma specialist nurse routinely visit. So that means the specialist comes to the patient rather than the patient having to wait for a bed to become available before they get seen. And the deal in exchange is that acute physicians are judicious and we refer wisely. So only around 20% of patients require a specialist. The rest are fine for general care. I mentioned enhanced care units, so these bridge the gap between intensive care level and a general medical ward level, and these are for high acuity, high risk patients such as respiratory failure, sepsis and post-thrombolysis monitoring. In my patient, the acute physicians look after the HDU. We have NIV, vasopressors, high flow oxygen, continuous cardiac monitoring. We will look after all of the type 2 respiratory failure, DKA, status epilepticus, overdose, GI bleeds, for example. The model requires enhanced staffing, so a minimum of 1 to 4 nursing staffing, increasing to 1 to 2, but it's a wonderful environment for the patients, and it's also a wonderful place for staff retention and training. How are we as a college helping? So we are pleased to work with our sister colleges in London and Glasgow to develop the curricula and manage the curricula for acute medicine. We also influence and engage on policy within the UK. We provide a wide range of acute medicine education. So this is an example of a website for our career support, but we arrange a number of events throughout the year focused on it. And as of last year, we also launched RCPE Advanced, which is an asynchronous digital platform which includes a 6-day course on acute medicine with days focused around medical HDU, SDEC, holistic care at the front door, acute frailty, and many more. And the feedback for that has been phenomenal. Okay, the first bell is gone. I don't want to incur the wrath of the second one. So I will say thank you so much to my dear friend Samaya and to the PSIM and everybody here for entertaining my conversation about acute medicine today. Thank you.
Thank you very much, ma'am, for highlighting the key pillars of acute medicine.